Welcome to the lecture entitled Anatomy of the Breast in the Female. My name is Carlos Andres Suarez-Quian. I am the creator and narrator of this lecture. This lecture is divided into two parts. In the first part, I will describe the gross anatomy of the breast, including the blood supply, lymphatics, etc., and I will include the surface anatomy of the breast. In the second part of the lecture, I will describe some surgical approaches used to treat breast cancer based on its anatomy. Let's begin. This description of the breast brings me to the four objectives that we will describe in this short introduction of the breast. At the completion of this lecture, you should be able to explain the position of the breast on the chest wall in relation to the skin, superficial fascia, and pectoral muscles. 2. Describe the anatomical structure of the breast itself. 3. Describe the principal lymphatic drainage of the breast. And 4. Describe breast cancer presentation in terms of breast anatomy. The breast, or mammary gland, is a structure found in the thoracic region of both males and females, more prominently in the female. It lies completely within the subcutaneous tissue. That is, it may be considered as a skin appendage. The boundaries of the breast include the following: superiorly, the clavicle; medially, the lateral border of the sternum; inferiorly, the anterior rectus sheath; and laterally, the breast can extend into the axilla as an axillary tail. If this is your first gross anatomy lecture, these descriptive terms for location may be unfamiliar to you. If this is the case, stop the tape and look them up first before continuing. Let's start now with the anatomical description of the breast. On the left-hand side, a breast from a cadaver is demonstrated, and on the right, the same breast is exhibited after cutting away half of it to expose the underlying muscle layer. The breast consists primarily of fat and is located in the subcutaneous tissue. If I now zoom in on the cut edge of the breast, note the fat on the breast is completely above the deep fascia of the pectoralis major muscle. The deep fascia was removed from the pectoralis major muscle to expose this muscle in the dissection. That the breast is located exclusively in the subcutaneous space is again demonstrated in these two drawings. On the left side drawing, half of the breast has been cut away to demonstrate its principal constituent, fat, and all the breast is located superficial to the deep fascia overlying the pectoralis major muscle. In this image, the deep fascia was cut away to expose the underlying muscle. We now focus on the image on the right, drawn with more detail, and again observe the fat, deep fascia, and the pectoralis major muscle. Within the fat of the breast, we can also find ligaments that compartmentalize the breast. These ligaments are called suspensory ligaments of Cooper. These ligaments extend from the deep fascia enveloping the pectoralis major muscle to the skin and play a role in the diagnosis of breast cancer, as we will see shortly. For now, understand that the function of the suspensory ligaments of Cooper is to compartmentalize the breast into pie-shaped wedges. There is no muscle within the breast tissue that one can exercise to strengthen and to add shape to the breast. The last component found within breast tissue is the glandular tissue, shown in blue, responsible for milk production during lactation. The glandular tissue finishes developing during the last trimester of pregnancy in response to the hormonal environment during the pregnancy. Milk formed in the glandular tissue will enter the lactiferous ducts and makes its way to the nipple. Having described the interior of the breast tissue, let's now describe the specific components of the skin making up the breast. The pigmented area of the breast is known as the areola. This region becomes more pigmented after the first pregnancy in response to the hormonal environment in the woman. Since skin pigmentation is due to melanin concentration, this phenomenon is more exacerbated in the African American population. Indeed, an experienced obstetrician can discern whether a woman has carried a pregnancy to term simply by examining the pigmentation of the areola. The nipple is found within the center of the areola and varies in size and shape. The region around the nipple is supplied with smooth muscle cells. Hence, the autonomic nervous system regulates the area of the nipple and helps explain why the nipple contracts upon stimulation. The same condition occurs when an individual is subjected to cold weather, that is, goosebumps. The goosebumps are the response to the cold stressor. The nipples also enlarge during lactation. This is a biological response to the need to provide the milk nutrients to the nursing baby. Finally, areolar glands produce sebaceous secretions to help lubricate the skin of the nipple and areola. Nursing can initially be painful to the skin of first-time nursing mothers, and the secretions help to minimize this pain. As you have probably observed, there is almost no difference in the appearance of the breast in a newborn, whether the newborn is a genetic male or female. This concept is demonstrated in this series of drawings that represent the newborn to the pregnant female moving from right to left. At puberty, differences begin to emerge, and at late puberty, when hormonal stimulation kicks in, gland development and fat deposition begins in earnest. The final development of the breast occurs during late pregnancy, and both the breast itself, as well as the areola and nipple, as previously stated, undergo final differentiation. People may wonder if breast size matters with respect to the ability of producing sufficient milk to feed the newborn. As stated previously, the size of the breast is mostly due to the amount of fat present in the subcutaneous tissue. All women express approximately the same amount of glandular tissue, the tissue responsible for lactation. Inability to lactate may be due to several causes, and these will be discussed in other courses, not here. As to why there are only two breasts, it should be pointed out that this is not always the case. The breasts develop in utero along a mammary crest around 7 weeks, as shown in the slide. This is a period prior to human sexual differentiation and may explain why males also have breasts and nipples. The mammary crest ultimately begins to regress by 8 weeks, and only 2 spots remain where the breast will develop. Here, for example, are individuals with polymastia, or multiple breasts, and the supernumerary breast can be functional. Note that in the male, the image on the right, the polymastia is evident solely by the remnant of a third nipple. Indeed, I have always wondered whether the legend of how Rome was founded by the twins Romulus and Remus that were raised by a wolf is nothing more than that their mother had polymastia, and in time this fact was transposed to a she-wolf. it is certainly a more colorful story, albeit apocryphal. And polymastia is not the only issue with breast development. Here are others. Gynecomastia, which is excessive development of male mammary tissue. Athelia, or the absence of nipples. Amastia, the absence of breasts. Aplasia, the difference in breast size. And inverted nipples, which makes it difficult for breastfeeding. These are a few of the pathologies associated with the breast. Given that the breast needs to be metabolically active during lactation, it is not surprising that it receives a robust arterial supply. These branches arise from the subclavian artery, the right and left subclavian arteries, although only the left one will be shown in this example. The specific branches arising from the subclavian artery include the internal thoracic artery, also known as the internal mammary, and the lateral thoracic artery. Smaller, unnamed branches from these two main branches provide the breast with redundant blood supply for its needs. Given the extensive blood supply that the breast receives, it is also not surprising that there are ample lymph nodes and vessels serving the breast to accommodate the tissue fluid that escapes the venous return. The naming of the lymph nodes is based on their location, and we can readily identify axillary, subclavian, and peristernal lymph nodes. There are additionally named lymph nodes, but these are better left for the pathology experts. It should be emphasized, however, that breast lymph drainage is of significant clinical relevance. Interestingly, clinicians divide the breast into 4 quadrants as shown in the image. These include the superior lateral, the inferior lateral, the inferior medial, and the superior medial quadrants. It turns out that the main lymph drainage of the breast, approximately 75%, is to the superior lateral quadrant, and from here the lymph makes it to the various axillary lymph nodes. Thus, one take-home message is that the lymphatic drainage from the breast is not homogeneous. As an aside, let's take a diversion and bring up coronary bypass surgery as it relates to breast arterial circulation. As the name implies, coronary bypass surgery is simply to use an artery to generate a graft distal to where a plaque blockade is preventing the flow of blood in a coronary artery. It is now common to use the left internal thoracic artery or internal mammary artery as a graft to bypass coronary blockage. The exceptional redundancy of the arterial supply to each breast makes this possible. But what if there's a second plaque? Can the second internal mammary artery be used? While the specific answer is yes, it is not common practice not to do so. The reason for this is that the internal mammary also supplies the sternum, as shown in the slide. And if both internal arteries are used for grafts, the sternum will be left in a weakened state. Instead, as you have probably heard, venous grafts are commonly used in cases where coronary bypass will be performed as multiple numbers. One common source of venous grafts is the great saphenous vein that runs on the inner thigh, and surgeons have developed extensive expertise in harvesting this vein for coronary bypass surgery. Let's now discuss the issue of the breast that most people dread hearing about, a lump in the breast. As indicated in the figure, it is possible to palpate tumors within breast tissue by gently pressing the skin of the breast and rolling it. If a tumor of a certain size is present, most people will be able to discern the presence of the lump within the breast tissue. This can be worrisome if there is a history of breast cancer in the family. The good news is that not every lump in the breast is cancer. As the table indicates, only about 10% of the time will a lump in the breast represent cancer. Nevertheless, women in the U.S. have a 1 in 8 lifetime risk of getting breast cancer. Hence, any lump in the breast should be examined by a physician and appropriate action taken. As to where in the breast do most breast cancers occur, it is to the superior lateral quadrant as indicated in the image, the same quadrant that receives 75% of the lymphatic drainage. The question then becomes, what are possible steps to take to diagnose the presence of a frank cancer in the breast? On the left side, I show you the image from before where a breast tumor is present and the clinician palpated the tumor to feel the lump. On the right, a breast cancer is being diagnosed by palpation. How is this possible? Simply by palpation? Think back to breast tissue. If you recall, breast tissue is compartmentalized by the suspensory ligaments of Cooper. If the breast tumor is growing rapidly, the probability is that it has invaded one of these ligaments and shortened it. Remember, the ligaments extend from the deep fascia to the skin. Hence, if they are shortened by the rapidly growing tumor, there's a chance that the skin is dimpled over the growing tumor. This phenomenon of dimpling can be exacerbated by palpating the breast as indicated in the image. That a patient is likely to be experiencing breast cancer can indeed be discerned from the appearance of the breast and understanding the anatomy of the breast just discussed, as well as the biology of the cancer itself. For example, dilated veins are present in tissues in which arterial blood supply increases rapidly and demands to increase metabolism, a feature of rapidly growing cancers. The dimpling of the skin, as just discussed, is also a sign of a rapidly growing and invasive tumor. In this situation, the ligaments of Cooper have been shortened. Skin edema results from the blockage of the lymph nodes by the cancer metastasis. Inability of tissue fluid to escape the tissue leads to edema. In the breast, the skin takes the appearance of the skin of an orange, peau d'orange in French. And finally, there is the image of nipple retraction. Such events occur when a rapidly growing carcinoma invades the mammary ducts, causing the retraction of the nipple. These are all hallmark images representing breast cancer. However, what is currently done when a small tumor is first felt by the patient or the clinician? What should be done? State-of-the-art technology relies on imaging, a term called mammography. A diagnostic mammography is performed to determine the nature of the tumor. 2 images of the breast are done as indicated in the slide of breast mammography. One from the top, a cranial caudal view, and one at medial lateral oblique view, approximately at a 45-degree angle. The results of the diagnostic mammography are giving a BI-RAD score for breast imaging reporting data system of from 0 to 6. In the BI-RAD score, a 0 usually entails a finding that requires further imaging evaluation, and a score of 1 is negative, a normal study. In contrast, a 6 means that a known malignancy is present. You will learn more about breast cancer management and the significance of these scores in pathology. For now, let's look at the two images rendered from the right and left cranial caudal views, and the two from the medial lateral oblique views. In these 4 images, there is no sign of cancer. However, here the mammography results from a different patient that is clearly showing a cancer. An irregular shaped mass is highly indicative that this patient is now suffering from breast cancer. But the final diagnosis of whether a patient truly has cancer requires a biopsy of the tumor and a pathologist reading the biopsy. It is at this time that the final diagnosis of breast cancer is made. While we have been discussing diagnostic mammography, let me remind you that screening mammography is still done in women who do not have a palpable breast mass. The principal advantage for this test is that yearly screening mammograms result in significant reduction in mortality and morbidity from breast cancer. The main disadvantage is that of false positive, but these have minor consequences. This concludes the anatomy portion of the breast lecture. However, if you're interested in learning about surgical options and also how the anatomy of the breast is exploited to perform the surgical procedures, please look at part 2 of this lecture.